and I'm a registered nurse. I'm the nurse manager over at Inside Connection. I actually also attended Western Wyoming's nursing program, and I graduated back in 1996. Wow. I know. And then I didn't start my first nursing job until 2001, and that was in Salt Lake City at Primary Children's. I worked in the NICU for 6 years, and then I also did a little bit of PICU for about 2 years. And then we ended up moving back here, and when we moved back here, I did a little bit of everything. First, I started out in hospice, which was not for me. That's the good thing about nursing, is there's a lot of opportunities. And then I was a school nurse for 3 years. Then I went to the ER for a little bit. I was missing the critical care part of nursing. So I was in the ER for about a year. And then I started at Inside Connection about almost 3 years ago. When I started at Inside Connection, I did not know that it existed in our community. So I'm sure a lot of you don't know that it's there either. It's a fairly new center. It opened up in 2014. We are a pregnancy resource center. We're open Tuesday, Wednesdays, and Thursdays from 10 a.m. to 4 p.m. This is our staff. There's me on staff as the nurse manager. We have a receptionist, Diana. Lori Longfellow is our executive director. Louise Wright is our center director. Holly Keller is our community outreach coordinator, and she's the one that coordinates our Learn While You Learn program, which is a parenting classes. And then we just added on another nurse, Tina Skinner. She's also an RN. We added her on almost a year ago. Jody Rhodes does our bookkeeping. And then we do have two medical directors, Dr. Fred Maddie, who's a radiologist up at the hospital. And then we just added on Dr. Mercer, John Mercer, who is over at Health Dimensions. We added him on this summer. So they are our oversight, our medical oversight. Pretty much our center is there for unplanned pregnancy. Some people call it crisis pregnancies. Ours is mostly unplanned, is how we like to term it. Because there are women who come in who aren't just in a crisis. They're also married and maybe have 3 kids and then find out they're pregnant and aren't prepared for another kid. So our goal is to give you as much information as we can about all of your options. All of our services are free and confidential. So the services that we offer are prenatal health, pregnancy options. We do provide limited obstetric ultrasounds, parenting classes, childbirth classes, post-abortion support, and pregnancy support. So being that we are not funded by government, we're not funded by anybody except donor. We're totally donor supported. So we are a faith-based organization. So we do not refer for abortion, but we will give you your options. We will sit down and discuss that with you. We'll talk about that with you. But being that we are not government funded, gives us the opportunity to not have to meet a certain criteria of who we target and who we're reaching out to. But we technically aren't under HIPAA privacy because we don't deal with Medicaid or any billing, but we do have a confidentiality policy and follow it anyway. So our prenatal health includes teaching, which would include nutrition, getting adequate sleep, of course, drugs and alcohol. We ask them about those things in their paperwork that they come in and fill out. Talk about smoking cessation if that's something that they need, and STI testing. We don't do STI testing, but on the paperwork that they fill out when they come in, it does ask if they've ever been tested for an STI, and if they have, if they've been diagnosed with one. If they haven't and they end up having a positive pregnancy test, then we really encourage them to follow up with family planning and head over there to get tested, because the STIs can affect the pregnancy outcome. If they do have a positive pregnancy test, we offer their first month prenatal vitamins. We give them a supply, so we do teaching with that, telling them when to take it, side effects they may have from that. A huge prenatal health that we do is follow-up. So usually, well, mostly all of our clients that come in have not seen an OB provider yet. The majority, I'd say probably 90%, don't have insurance. So when they come to us, they haven't seen an OB provider. They need the pregnancy test. We also do the medical grade. We give a verification of pregnancy test so that they can take to an OB provider. So the one situation is if they don't have an OB provider, we will give them a referral list. We have a referral list that actually, just to talk a little bit about the Best Beginnings coordinator, Linda, she comes up with this referral list, and she sends them out to all the agencies in the community. So it has, family planning, it has WIC, it has all of our resources in our communities, including OB providers and pediatricians. So we'll hand this out to them. Really encourage them to follow up with an OB provider. If they don't have insurance, then we make a referral to Linda at Best Beginnings, and she starts them with the presumption of eligibility for Medicaid. If they do have insurance and have an OB provider, then we do send them there. When they come in and fill out their forms, we do have disclosures and consents too, and on there is stating that we do not provide follow-up OB care. And so we really try to get them in to see their OB provider in those very first few weeks to start early prenatal health. We also will give them support, such as the parenting classes that Holly, our community outreach coordinator, does, childbirth classes that are taught by we have 2 birth doulas that do those, and community referrals. With the parenting classes, they go up until, I believe, 2 years of age, and they can be volunteer, but we are seeing a lot more that are court-ordered through DCFS. So when they come in with that, there's strict guidelines they have to adhere to, and again, they also sign a release saying that we can communicate between us and their caseworker. No matter if it's court-ordered or not, if it's voluntary, they have the opportunity to earn baby bucks, which is kind of like Monopoly money, and for each lesson that they complete. Each lesson they complete, they earn the baby bucks, and they can go into our boutique and buy things with those baby bucks. So our boutique is also solely donor sponsored. So we have layettes, we have diapers, we have formula, we have a lot of clothes. So they can choose to use those baby bucks for supplies that they need.
Kimmy, is that the same as the cut house? Is that what it used to be?
I don't think so.
Oh.
I've never heard it called that.
Okay.
How long has that been around?
I don't know, Missy did it. Missy was doing that kind of thing.
Well, I know Eileen's attic also was doing it.
Okay.
And so we would let them use our baby bucks there too. So,
that's nice.
yeah. So the pregnancy options, when they come in, I was going to do the case study at the end, but maybe I should do it at the beginning. So then I could have gone through the whole thing. So the pregnancy options is really what we like to talk about them with. When they come in, they do the pregnancy test. They come in, they fill out the paperwork. We take them into our client advocate office. Our client advocates will sit and talk with them, usually just one. And I go in there, we explain to them the procedure. Then we go do the urine test, it's urine. Then take them back into the room. While they're in the room with the client advocate is when I run the pregnancy test. When they're in the room with the client advocate, she talks to them a little bit about how they're feeling about their pregnancy, what their intentions are, whether they intend to carry whether they're looking at adoption or whether they're feeling like they want to abort. She'll go into that a little bit with them, giving them their options, kind of getting a feel for where they're at. We do have, I think it's on this one. These are just our resources, so they're not necessarily within our community, but resources that we give them. There are I believe two adoption attorneys on here that we give them. We don't give them potential adoptive families to contact. We just say, here's the adoption options that you have. There's open adoption, there's closed adoption, there's semi-private adoptions, and just talk a little bit about everything with them. Then I'll come back into the room, ask them if it's okay if I disclose their test result with others present in the room. Usually we just have the client in the room. Sometimes they do ask if their family member or a friend can be in there. We really try to just get them in the room. That way they're more free to communicate and they're not being influenced by whoever else is with them. We tell them if the test is positive, it's a positive test, but it is not a confirmation of pregnancy. Positive test means that you have that hormone, the HCG hormone in your urine. So to confirm the pregnancy, if they are abortion-minded or abortion-vulnerable, we encourage them to do our limited obstetric ultrasound. Let me pass through here. This is the parenting, the adoption, like I said, open versus closed versus semi-closed, and then the abortion. Like I said, we determine whether they're abortion-minded or abortion-vulnerable, which we have our criteria that we go by. We also talk to them about the abortion restrictions in Wyoming. Parent of a minor must consent and be notified before an abortion is provided in Wyoming. But like we said earlier, there are no abortion providers in Wyoming. So, public funding is available, like you guys were talking about, the public funding, in cases of life endangerment of the mother, rape, or incest. No abortion is provided after viability, which viability, according to Wyoming, is 24 weeks. In other states, they determine viability differently. So, unless it's necessary to protect the woman from imminent peril that substantially endangers her life or her health. As of July 1st, Wyoming requires an abortion provider to inform women that they can see an ultrasound of their unborn baby before having an abortion. So prior to that, they did not have to do that. So our limited obstetric ultrasound inside connection, if the test is positive and they're abortion-minded or abortion-vulnerable, also have to meet a few other criteria in order for us to do that. The client has to be at least 6 weeks from the first day of her last menstrual period. 6 weeks is when you can see the heartbeat on ultrasound. The heart starts beating at 18 days, but you can see it on ultrasound at 6 weeks. You can't see it usually before then. So that's why we like the 6-week mark. The client has had no previous history of ectopic pregnancies or tubal. You may have heard it as tubal. Because if she has, then she puts her at a higher risk of having another tubal. And so also, she doesn't have an IUD in place. An IUD also increases her chances of having a tubal. So any of those, if she's clear with all these, then we can go ahead and do the limited obstetric ultrasound. The Pregnancy Help Medical Clinic setting, this is the type of ultrasound exam that is undertaken in order to provide the abortion-minded or abortion-vulnerable patient with vital information to enable her to make an informed choice. So that is really what our goal is to inform them of all their choices and make sure that they have the information that they need to make that choice, that they're not going into it not knowing. We do the limited obstetric ultrasound, just the nurses do it. We have special training that we have to do, tests that we have to take. But we are limited in that we are only doing the ultrasound to answer 3 questions. Okay, we want to see if the pregnancy is in the uterus. So, and is it a viable pregnancy? So a viable pregnancy would have to be in the uterus and have a heartbeat. And what is the estimated gestational age? We go based on measurements. So if a woman is abortion-minded or abortion-vulnerable, we always tell her, let's make sure it's a viable pregnancy before you have to make that choice. Because that choice may not be hers. If it's not in the uterus, or if it doesn't have a heartbeat, she's going to miscarry. And she doesn't have to make that choice for herself. It's already been decided. If it is, then we go from there. And we say, okay, it is, you do have a pregnancy in the uterus. It does have a heartbeat. Usually after we do the ultrasound, we'll ask them again, what are their intentions. Whether they choose abortion, adoption, or sometimes the ultrasound ends up changing their perspective, or ends up that they don't realize what they're seeing as a baby. They'll be undecided. We try to make it really clear to them that no matter what it is that they decide, we will be there to offer support. I think that's the huge thing with any pregnancy is the woman being able to have support and options. So, telling them if you need to come back in, if you want to bring a family member, we can do a second ultrasound. It's called a familial scan. So for family reasons, if they want to come in, if the father of the baby wants to see, if they know that the person that's going to be helping them with the baby needs to see it, then they can bring someone else in. They can also bring that person in the first time too. It's totally up to the client.
There's a question over here too.
Yeah.
Is the limited ultrasound, is that only available for clients that are thinking about abortion, or is this any patient that comes in with a pregnancy, can they be offered this service?
So, yes. They have to be abortion-minded or abortion-vulnerable. When I first started, we were doing them for everybody, but we kind of, in better collaboration with the OB providers here, if they intended to carry and wanted to parent and had an OB provider, we really wanted to work with them and say, see your OB provider first. And then once your OB provider has cleared it, you can come back and be one of our training models. And so our training models can be anyone up to from 6 weeks to 24 weeks. And that is for our training purposes. We have to have so many scans per month to remain competent. So, and those images we don't send to our medical director. So once they've seen their OB provider is fine with it, then great, come back and see us. And then we also encourage them to come back for our parenting classes or our childbirth classes or, yeah.
Is there any thought, I know one time there was discussion about ultrasounds, repetitive ultrasounds causing damage?
Yes.
What's the school of
So
thought on that right now?
we use the lowest, I can't find the word. Yes, we use the lowest frequency. So that's why they can only see the heartbeat. They won't be able to hear it. Audible takes a higher frequency, but when we send them to the OB provider and say, after you've seen them and they've cleared it and come back to us, you have to be a month out. Like usually when they go see their OB provider, if they're coming into us about 6 to 9 weeks, they're going to their OB provider about 10 to 12 weeks. They're not coming to us again until about 14. So we tell them if they do an ultrasound at 10 weeks on your first visit, which they normally don't, you have to be a month out from your last scan, is what we like to tell them. That's what we follow. Okay, so here's the case study. You guys have questions up till now? No? Okay. So we have a 22-year-old female college student who's not married, but with her boyfriend. Her health history includes that she's a smoker. She's G1, P0, and EAB times 1. Do you guys know what EAB is? Elective abortion.
So
she's had one elective abortion.
I don't know if they know G or P yet.
Okay,
either.
so
They're
G
reading.
is she's been
Oh.
pregnant. Sorry, she's been pregnant once. And P is para. She has had no live births. Okay. Her last menstrual period was October 1st, so that puts her right around 8 weeks. 8 weeks, 2 days. She's had no history of fetal ligation, ectopic, or IUD. She is sexually active, without insurance, and she's also on alprazolam. She states, I didn't want to get pregnant. I just don't feel ready to parent. My boyfriend and I are fighting about it right now, and I don't know what I want to do. Her current life stressors that she identifies are her finances, school, work, and relationships. She's teary throughout her visit and cries at times. I try to add subjective and objective.
Good.
So, based on this information, how many of you would say she's likely to carry? How many of you would say she's abortion vulnerable? Do you guys want me to read the definition of each?
Yeah.
Okay, sorry, I should have done that. So this is the criteria we use. Abortion-minded means client is planning or intending to obtain an abortion. Client is seeking information as to how to obtain an abortion. For example, can you tell me where I can go for an abortion? Client has an abortion scheduled. The abortion procedure has been initiated. Or she exhibits any of the above criteria. Abortion vulnerable means she faces obstacles that she may feel incapable of handling. She has not eliminated the possibility of abortion. She's being pressured to have or consider an abortion. She's undecided, and she expresses that verbally or in writing or in our intake form. She has a medical condition that she thinks may affect the pregnancy, or she has one or more of the above risk factors. So that's abortion vulnerable. How many would say this client is abortion vulnerable? And how many say abortion minded? So there. Yeah, we would identify her as abortion vulnerable. So she came in, her test is positive, she has this history, so we're going to offer her our limited obstetric ultrasound. We'll ask her if there's anybody else she wants in the room. We usually will not bring that person in until after we've completed the entire ultrasound. We start with a transabdominal ultrasound and get some images, and then we do a transvaginal ultrasound, which gives us a much better picture of what we want to see at that early. Once we do all our measurements and get all our information that we need, she then can bring whoever else in that she wants, if she chooses. With the abortion-minded or abortion-vulnerable client, you have to keep in mind they may not want a picture of the ultrasound. They may not want the prenatal vitamins, so we always ask. Also, we always tell them in our disclaimer, there's a lot of forms for them to sign, and it's in those forms that this is not confirmation until our medical director reviews it. We then send our images, we make a report, send it to our medical director, whichever one is on at the time. They send us a report back and let us know what they confirm. So we always let them know this is not confirmation until the doctor has reviewed it and he makes his either recommendations or adjustments or.
How long does that usually take to get that from the doctor?
Within 24 to 48 hours. Usually we tell them. So usually it's the next day. If we're open on a Thursday, it won't be till Tuesday that we get back to them. If we see something that concerns us on the ultrasound, which is the client is 10 weeks along and we can't find a heartbeat or we don't see the pregnancy in the uterus, we will let the client know that. Tell them they need to follow up with an OB provider within 48 hours. And also call our medical director and let them know. If they're having any bleeding, cramping, or pain that day on their questionnaire, on their ultrasound intake, we also will not do an ultrasound if their pain is greater than a 6. Do you guys know the pain scale? Okay. So if their pain's greater than a 6, then we also won't do an ultrasound that day. We'll tell them to follow up immediately. In our ultrasound training, if we cannot confirm an intrauterine pregnancy, then you always have to suspect that it's ectopic. And if that's the case, then we tell them to follow up immediately. Sometimes we'll call from our office, we'll call their OB provider. So, not only we do an limited ultrasound, but we have to look at the whole picture because sometimes if they're abortion-minded or abortion-vulnerable, they don't want the ultrasound, and that's fine. But we try to address the other issues that are there. You know, she's smoking and she's pregnant, so we have pamphlets that we'll give or talk to them about that and about smoking cessation. She also, what else do you see on there that might be a concern? On her and her boyfriend fighting?
Yeah.
Yeah, maybe. Ask her that. We would probably say, do you feel safe in the situation you're in? What else? For meds. We do have some that come in and feel like they can't carry because they're of the type of medication that they're on. They're really concerned about how that's going to affect.
How do you respond to that?
So we'll usually talk to them about that medication, but mostly we'll say you need to contact the provider who prescribed that medication. Let them know that you think you might be pregnant, or if she's already taken the test, you can take them this verification of the test here and see what they want you to do. And we'll usually tell them you need to follow up with that immediately.
Do you tell them not to quit abruptly though?
Yep. Yep. That's up to their provider, prescribing provider, how they want to do that. So, oh, there's another one in there on health history. Yep. Yeah. So if they're still sexually active and they didn't want to be pregnant to begin with, what can we do to prevent this in the future? What can you do to change this situation that you're in right now? And that even goes for the client that is not abortion-minded and abortion-vulnerable. That goes for all of them. There's even ones that come in married that weren't expecting that. And so, and you would be surprised, like has been said before, what they know and what they don't know. So,
What percentage of clients do you think roughly come in who are pregnant or who are married?
maybe 40%. It's pretty high.
That's surprising.
And after I started working here, we were thinking, in my mind, I don't know if it's in your mind, but in my mind, the abortion-vulnerable, abortion-minded client would be your teenager, younger, high school student. No. According to the statistics, it's your college, married, educated women. Which is really surprising. So we were like, oh, we're targeting the wrong demographic.
How many people do you think you guys see that just, they thought they were using a contraceptive, right, or they didn't really know how to use it, or they thought they were breastfeeding and they could get pregnant, or how?
A lot, probably 90%. Or they're not using anything. On the questionnaire, it'll ask, are you using contraception? And then it'll give them all their choices they can mark. And then the next question is, did you want to get pregnant? And so a lot of them will say they're not using anything, but that they didn't want to get pregnant. So if that's the case, because we don't offer contraception, then we refer them to family planning. We do a lot of referrals to Best Beginnings to Linda because probably the 90% come in without insurance. And that's the one hindrance to anything, to contraception, to prenatal health, to women's health. For them to even be getting their yearly, they're not doing. But we can refer them to family planning if they're not pregnant, but we can't refer them to Best Beginnings to Linda unless they have that positive pregnancy test, because they need to have that positive test to be eligible for Medicaid.
If they are abortion-minded, where do you guys refer them to?
We don't refer.
Or, like,
So-
the pamphlets that you give them is just information about it?
Right.
Okay.
So it would be, like we do the before you decide. So it gives them all their options. We would give them the referrals for local community resources that they could go to. But yeah.
Now, what do you do about a client who isn't on any contraceptive and she doesn't believe in contraceptive and doesn't want to get pregnant? Do you just counsel her on ways to know her body?
Yeah, it would be like a natural birthing method, so they would teach her how to track when she's ovulating.
So you guys can do that?
Yes.
Okay.
Yep, and we can talk to them about birth control. We can talk to them about, condoms and the pill, and we talk to them about Norplant and IUDs, and if they come in having questions like that, we can, yeah. Even if they don't come in and have questions like that, and like I said, when we meet with them, we'll say, are you using contraception? And is that working for you? And so if they have, and some will come in and say, well, I had, and a lot of times they won't know. They'll just say, I had something injected, or I usually get a shot. They won't say it was a depot shot or anything like that. But I stopped getting them, and then I never got a period. So we'll talk to them about that. But we always refer them back to either their primary care provider or an OB GYN to follow up. If you're thinking it's been misplaced, or if you still haven't had a period, go see your OB provider. Or if they come in and they haven't had a period for 2 months, but their test is negative, we'll say you need to follow up with an OB/GYN to figure out why you're not having a period. Yeah. Any more questions?
So for the counselor person who they see at the beginning, what did you call that person?
So we call them a client advocate.
Client advocate. And what are their credentialing?
So because they're not licensed counselors, so we don't want to say we're counseling them. We don't want to give them the impression that we're licensed counselors. They do have training. We are actually affiliated with NIFLA, which is the National Institute of Family and Life Advocates, and also with Heartbeat International. So they're national organizations that,
Can you say that again? What was it?
NIFLA, National Institute of Family and Life Advocates. And so that is where we derive our policies and procedures from. They have annual conferences. That's where we get all our training through, and also Heartbeat International. And so we do training through there for our client advocates. But they will talk with them pretty much about everything that a counselor does, but if we feel like, gosh, this is over what we can give them, we refer to someone else.
And are both of those agencies faith-based?
Yeah, NIFLA and Heartbeat International? Yes. Yep.
Do you receive funding from those organizations?
Not from NIFLA or Heartbeat, no. Our only funding is donor funded. So we
Is
are
donor, private donors?
Yes, we are solely supported by people in the community.
Do they pay your salaries?
Yeah, well, our two RNs are paid staff. Our center director is paid staff, and our executive director is paid staff. The others are all volunteers.
Wow. So all of those are donation based? That's how you
Yes.
receive your
Yes.
livelihood?
Yes.
Is that a pretty solid source of income?
For me?
Just for donation? No.
I'm like,
No, for donation based. Did you feel
yeah.
like there's enough support in the community?
No. No, not to do what we want to do. I mean, because we've looked at implementing STD testing, because the majority of our clients will come in and say, well, do you do STD testing too? And we have to say no. And in order to do that, we have to also be able to provide follow-up for that. And we aren't able to do that right now. A couple reasons, because we would need more staff. We would need a higher level provider, so a nurse practitioner or an MD. And we would also need more space. It would cost more in supplies. So it's just, that's our future. So, any other questions? Okay, thanks for having me, guys.